Welcome. Thank you for joining us. We're currently at the International Myeloma Workshop in Boston, and I'm joined by my two colleagues, Nikhil Munshi and Mateos. And we're going to talk about minimal residual disease. We've heard quite a lot about it at this meeting. We've been talking about it for a couple of years now, about when, who, how. Do you think we've reached any conclusions at this meeting, Dr. Munshi?
I think so. I think there's been tremendous amount of data accumulated over the last many years. In the initial part, we had small studies, 50 patients, 20 patients. So the large meta-analysis a couple of years ago that combined those data, and there were 1,500 patients. It all shows the same thing, that getting MRD negativity provides better outcome. Improved PFS, improved OS when the data was available. Now today, within the last 3 to 4 years, large studies have been done. The total number of patients is around 8,000 who have had MRD measured and evaluated. And so there's really large amount of data collected that shows the same thing, that if you get MRD negativity, you get a better outcome. So I think there's reasonable consensus.
That's good. We agree on one thing. That's always a step in the right direction.
Good start.
There seems to be two different tests that people are using, Marivi. Do you want to just mention those a little bit?
Yeah, there are different ways in order to measure the minimal residual disease. First, we can measure the minimal residual disease inside of the bone marrow and also outside of the bone marrow. Starting by measurement of minimal residual disease inside of the bone marrow, we can use different techniques, next generation flow or next generation sequencing. Basically, both techniques are different because, well, as you know, by next generation flow, what we do is to evaluate directly the clone of plasma cells. We are able to see the clone of plasma cells, the normal plasma cells, the abnormal plasma cells, together with the whole cellularity in the bone marrow. It is also possible to do next generation sequencing, in which we are going to evaluate the DNA of the tumor clone. So it's different because we are going to pick up the tumor clone, and we are not going to be able to see the rest of cellularity of the bone marrow. This means that, well, both techniques have advantages and disadvantages. But from my point of view, the main concept is that both techniques are equivalent in order to measure the minimal residual disease when both techniques are well done. And to do well measurement of minimal residual disease means to use the appropriate colors in order to evaluate, for example, by flow cytometry, the plasma cells, the phenotype of the plasma cells. And the second important point, the number of events to be analyzed, because in order to say that the minimal residual disease is negative means that we have to reach a sensitivity level of at least 10 to the minus 5. This is, from my point of view, much more easier for next generation sequencing. And in next generation flow, it's possible to reach it even 10 to the minus 6, but we have to take care about the number of events. And this is critical because flow cytometer is present in most labs around the world. But if the person in front of the flow cytometer are not able to do the good technique, the results are not going to be reliable, and we can say that this patient is in minimal residual disease negative by flow cytometry, and this is not the case. And this is, for me, the main mistake. And we can use PET-CT for the evaluation of minimal residual disease outside of the bone marrow. And the criteria are being standardized, and in the future we will use PET-CT or MRI, PET-MRI in the future for the minimal residual disease evaluation outside of the bone marrow, and inside of the bone marrow, either flow cytometry or next generation sequencing.
Excellent. And there's always been discussion as to which patients and at what time point. Are we any clearer about when and who we should be testing?
I think so. And I think the indication actually is more expanding. So in the initial part, a couple of years ago, it was always for newly diagnosed patients, getting induction, consolidation, CR, and then we measure. And I think that was the algorithm. But with more studies, I think this is expanded to also point that MRD negativity, even in relapse patient, may be of importance. So in newly diagnosed patient, when would you do MRD measurement? And there are multiple time points. In our studies, we do all over. We do it right after induction, right after transplant, before maintenance, after maintenance, but that's study. If you're treating patients, there are certain time points which probably are more appropriate than doing many time points. So I think when patient gets the best response, I think that's the time when we should measure MRD to see, is it deep enough? And it may help us guide the treatment or not. I think post-consolidation is another time point where we may want to do it. When we start maintenance, we may want to know whether it's MRD negative or not. And then later on, after maintenance at certain time point, could be another time point. And why do all these time points? So the first, at the best response, if somebody is MRD negative, that's really a good prognostic marker for us, that what is this PFS going to be? It may not change the treatment, however, it will tell us and tell patient, you're going to do great, you have expected long PFS. Why to do before maintenance and or during maintenance? Partly because before maintenance, we would then know if it is MRD positive, we may want to pause, although at current time, we don't change the treatment. We don't give longer consolidation, we don't give next line of treatment, but that's something in future where we may want to induce MRD negativity, and so that's a theoretical time point. On the long-term basis, I think question comes up, and we actually use it in practice when patients have been on Revlimid maintenance for 3 years. He wants to get off the treatment. However, currently in US, we want to continue forever, and so what's the balance? So if that patient is MRD negative, and I may feel more comfortable saying maybe we stop it, you have achieved a good remission. Versus if it's MRD positive, I might be a little bit concerned. So I think these are the general time points where there is some level of use. But an alternate place where I think measuring MRD, and MRD in that context is a wrong word, but measuring the minimal disease is important, is when patients say, for example, has achieved CR. He's still MRD positive. However, when we do the marrow, we don't find anything that pathologist says positive. But if you do the sensitive test, you're going to now look at 0.1% myeloma cell, which we can't otherwise find. Subsequently, 6 months down the line, with whatever you do, now that 0.1 becomes 0.01. Maybe we are now judging the below the surface myeloma burden, more sensitivity. So I think using this test in a different context may also be an important way of measuring, instead of pathologist doing what he does, staining and say, well, there's less than 1%, so it's negative. I think we may be more accurate. So using this test beyond strictly what we call MRD may be an important place for us to look at this. And I think there may be the evolving use of this test. Another place where I think this test would be important will be when patient has solitary plasmacytoma. We do bone marrow, say bone marrow is negative, is solitary, give radiation, and then wait and see what happens. We need studies, so I don't think we know enough. But those are the patients where I would do MRD measurement and see, is bone marrow really negative, or there are still clonal cells there. And having a biopsy from the plasmacytoma, we have material to do this. And then if it is positive, we may have to think whether it's a systemic disease or not, and then we can modulate our treatment. Again, this is area where we need some more research to know how frequently it is, but another area where we need to keep evaluating the value and the implication therapeutically.
Excellent. And Marivi, there's some data of its use in the relapse setting. Do you want to talk a little bit about that?
Yeah, so I think that in the past we considered the evaluation of minimal residual disease only in the upfront setting because really few patients were able to achieve good quality of the response at the relapse. But now the situation is changing, and we have excellent combinations that we use usually at relapse, 3 drug-based combination, new monoclonal antibodies, new immunotherapeutic strategies that are able to result in a high proportion of patients achieving complete response. In fact, with some of the new combinations, the complete response rate is higher than the complete response rate we get at the beginning in the upfront setting with conventional therapy. So why not to evaluate the minimal residual disease also at relapse? And in fact, this is what is being done in the clinical trials with excellent results, showing the same concept that Nikhil mentioned, the role of minimal residual disease negative as prognostic factor predicting better outcome. In the relapse setting, we have now data coming from benefit in progression-free survival, but we will have maybe in the future about overall survival. And not only the minimal residual disease evaluation at the moment of a complete response or at the end of one specific number of cycles, but the concept of sustained MRD negativity. And we have some data showing how when the minimal residual disease is negative 1 year apart, but it would be the same 2 years, while sustained MRD negativity is associated with a flat in the progression-free survival, what is relevant for us as physicians, but especially for the patient, because the information that we can give them is accurate.
Mm-hmm. It's been quite interesting hearing the different study groups and what they're planning studies to do, as you were saying, about studies answering about whether you need to give maintenance to MRD negative patients. Should you give more or less maintenance to MRD positive patients? When can you stop treatment? And all of those studies are ongoing or are just about to start, which is fantastic.